Welcome. Welcome to the deep dive. Have you ever paused to consider how something incredibly minuscule, truly invisible to the naked eye, can wield such a vast and varied influence over human health?
It absolutely does. It's quite something.
It's a phenomenon that truly shifts your perspective on the world, isn't it?
Definitely. These microscopic entities are masters of intricate biology, constantly adapting and often operating beneath our notice until their effects become, well, profoundly clear.
And today, we're taking a truly rigorous deep dive into some of these tiny titans, parvovirus infections. Our journey will lead us through Chapter 197 of our source material, extracting every crucial detail and concept.
That's right.
Our mission, really, is to unravel the intricate complexities of these microscopic invaders, understand their diverse manifestations, and arm you, the listener, with a level of insight that professionals in the field possess. Think of this as your expedited pathway to truly mastering parvoviruses.
That's the goal. And what's immediately striking about parvoviruses is their name itself, parvo, comes from the Latin for small. They are, in fact, among the smallest DNA viruses known.
Really small.
Yes, characterized by their non-enveloped structure and a unique fundamental dependency. They require rapidly dividing host cells, or even the assistance of other helper viruses, to successfully replicate.
Okay, so that dependency is key right from the start.
It is. It gives us a profound clue about how they operate and, what kinds of cells they can actually infect.
Before we jump into the nitty-gritty of parvoviruses, I want to briefly touch on something that appears right at the beginning of Chapter 197.
Okay.
The mention of vaccinia immune globulin. Now, if you're following along with the source, you might wonder why it's there.
Right. It's not for parvovirus.
Exactly. It's a licensed treatment, yes, but for vaccinia infections, not parvoviruses. We wanted to highlight it simply to assure you that we're meticulously covering all the information presented in the chapter, even brief tangents like this.
Good point.
To ensure our deep dive is as comprehensive as possible, we're truly leaving no stone unturned in our quest for mastery.
Exactly. Every piece of the puzzle matters.
So let's establish the foundational understanding. What exactly defines a parvovirus? What are its core characteristics that set it apart?
Okay. At their very essence, parvoviruses belong to the family Parvoviridae. Their defining feature, as their name implies, is their incredibly small diameter, typically around 22 nanometers.
22 nanometers, that's minuscule.
It really is. To put that into perspective, it's significantly smaller than even most bacteria, let alone a human cell. We're talking about a true nanoscale invader.
Almost unbelievably tiny.
Yeah.
What about their structure and genetic material?
Structurally, they are non-enveloped, meaning they don't possess an outer lipid membrane derived from the host cell.
Okay.
And this non-enveloped status is actually a key factor in their resilience, often making them more stable in the environment than, say, enveloped viruses.
More stable, right?
Their outer shell, called a capsid, has a robust, symmetrical icosahedral shape. And their genetic material is quite unique for a DNA virus.
Yeah.
A linear, single-strand DNA genome.
Single-stranded DNA.
Yes, this compact genome, roughly 5,000 nucleotides long, packs quite a punch despite its size.
You mentioned their crucial replication dependency earlier. Could you elaborate on why that's so significant?
Ah, yes. It's fundamental.
What are the practical implications of that limitation for how the virus behaves inside the body?
That dependency is a fundamental aspect of their biology and their pathology. Unlike many viruses that can co-opt the cellular machinery in a broad range of cell types, parvoviruses are highly particular.
Picky.
Very picky. They specifically require host cells that are actively dividing, undergoing DNA synthesis, or they need the assistance of other helper viruses that can induce those necessary cellular conditions.
Helper viruses, interesting.
This unique requirement severely narrows their target cell range, dictating which tissues and cells they can infect, and consequently, the specific diseases they can cause.
So it really limits where they can set up shop.
Exactly. It's a critical limiting factor that shapes their entire life cycle within a host. For instance, if a tissue isn't rapidly regenerating, parvoviruses will find it very difficult to establish a productive infection there.
So their pickiness about host cells really determines their passive destruction, so to speak. Now, in the realm of human health, how many distinct groups of parvoviruses have we identified that infect us?
Right, so within this family, Parvoviridae, scientists have identified at least 5 distinct groups that infect humans.
5 groups? Okay.
These include the widely known parvovirus B19, often just called B19V. Then we have the dependoparvoviruses, also known as adeno-associated viruses, or AAVs.
AAVs, right. Heard of those?
Next are the human tetraparvoviruses, which encompass PARV4 and PARV5. Following those are the human bocaparvoviruses, or HBoVs.
HBVs.
And finally, the human protoparvoviruses, a newer group that includes bufavirus, tussivirus, and cutovirus.
That's quite the lineage. Bufavirus, tussivirus. Quite the names. But the source material makes a very specific point about one of those groups, the AAVs.
It does, and it's an important distinction for our deep dive. Human dependoparvoviruses, the AAVs, are explicitly set aside from further discussion here.
Okay, why is that?
The reason is that, despite their presence, they are largely considered non-pathogenic in humans. Our mission is to master the clinically relevant aspects of parvovirus infections, to truly understand the disease-causing variants.
Makes sense. Focus on the troublemakers.
Exactly. Excluding AAVs allows us to focus our attention, sharpening our understanding of the parvoviruses that directly impact human health and cause disease.
Okay, that makes perfect sense for our goal of comprehensive understanding. So, let's now turn our full attention to the most studied and clinically significant member of this family, parvovirus B19, or B19V.
Right.
It's truly the poster child for human parvovirus infections.
B19V is indeed the quintessential member of the erythroparvovirus genus. It was the first human parvovirus to be discovered and is by far the most thoroughly investigated in terms of its role in human disease.
The first one found.
Yes. Its discovery really opened the door to understanding this entire family.
And even within B19V itself, there's genetic diversity, correct? How does that play out globally?
Absolutely. Based on its viral sequence, B19V is categorized into 3 distinct genotypes, 1, 2, and 3.
3 genotypes.
And the geographical distribution of these genotypes is quite intriguing. Genotype 1 is predominant in most parts of the world. It's the one you're most likely to encounter in a typical clinical setting.
The common one.
Yes. Genotype 2, on the other hand, is quite rare and is seldom linked to active infections. Interestingly, genotype 3 appears to predominate specifically in parts of Western Africa.
Western Africa.
Yes, hinting at a fascinating evolutionary and epidemiological story tied to regional populations.
So we have these genotypic variations. Does that mean our immune system needs to produce different antibodies for each? Or is there some cross-protection?
That's a crucial insight for understanding immunity and, potential vaccine development. Despite these genetic variations among the 3 genotypes, only a single B19V antigenic type has been described.
Only one antigenic type. So they look the same to the immune system.
Essentially, yes. The outer proteins the immune system recognizes are largely similar across all genotypes. Consequently, once an individual mounts an immune response, particularly developing neutralizing antibodies, that protection is expected to be effective across all 3 genotypes.
Okay, that simplifies things immunologically.
It simplifies the immunological picture significantly, yes.
That's a huge piece of information for understanding protection and epidemiology. Let's delve into that epidemiology more deeply. How does B19V spread, and who does it typically affect?
Okay. The epidemiology of B19V reveals a truly pervasive virus. It's exclusively a human pathogen. There are no known animal reservoirs.
No animals involved.
Which simplifies control measures somewhat, and it's endemic virtually worldwide. You'll find evidence of B19V exposure in populations across every continent.
Wow, everywhere.
Pretty much. The primary mode of transmission is predominantly via the respiratory route.
Respiratory, okay.
Through droplets from coughs, sneezes, or close contact, similar to many common respiratory viruses.
So it's quite widespread and easily transmitted. Does that translate to widespread exposure over a lifetime?
The seroprevalence data paints a very clear picture of widespread exposure. There's a striking progressive increase in detectable IgG antibodies to B19V with age.
IgG indicating past infection.
Correct. By the age of 15, approximately 50% of children have detectable IgG, indicating prior infection. This figure climbs dramatically to over 90% among the elderly.
Over 90% in the elderly.
Yes. This tells us that by the time you reach adulthood, particularly older adulthood, it's highly probable you've been exposed to B19V at some point in your life. It's a common childhood infection for many.
That's a massive percentage. What about its transmissibility in specific settings, like within families or in healthcare environments?
In close contact settings, like within households, B19V is quite efficient at spreading. Secondary infection rates within households can approach 50%.
Half the household might get it.
Roughly, yes, if it's susceptible. Meaning, if one person contracts it, roughly half of the other susceptible household members are likely to become infected. This high transmissibility makes it challenging to contain once it enters a family unit or, say, a school setting.
And the risk during pregnancy. That sounds like a particularly sensitive and concerning area.
It is indeed. The estimated annual seroconversion rate, meaning new infections in pregnant women, is about 1%.
1% per year.
While this might seem like a low percentage, the potential impact on the developing fetus can be severe, making it a critical concern for maternal and child health. We'll definitely get into that more.
Okay. You touched on the presence of B19V in blood earlier. How does that translate to the risk of transfusion-related transmission, and what measures are in place to manage it?
Yes, this is a critical aspect of blood safety and a significant concern. High-titer B19V is not uncommon in blood donations.
High levels in donated blood.
It can be, yes. And transmission can absolutely occur through transfusions, especially of pooled blood components like plasma, which are derived from multiple donors.
Pooled plasma, right. Higher risk there.
Exactly. To mitigate this significant risk, plasma pools intended for transfusion are now routinely screened using nucleic acid amplification technology, or NAT.
NAT screening, that's the DNA test.
Precisely. It's a highly sensitive test that detects viral DNA. Any high-titer pools indicating a significant viral load are simply discarded.
Discarded, good.
This is a vital public health measure that has dramatically reduced the risk of transfusion-related B19V infection.
That's reassuring. But is B19V particularly resilient to common sterilization methods for blood products? I think you mentioned that earlier.
Unfortunately, yes. B19V is notoriously resistant to both heat and solvent detergent inactivation.
Wow, it's tough.
It is. These are common methods used to inactivate many other viruses in blood products. This inherent resistance makes it a persistent challenge in ensuring the safety of blood products and underscores precisely why NAT screening is so crucial.
So the screening is really the main line of defense then?
It remains the frontline defense against B19V transmission through transfusions, absolutely.
Understanding the transmission and prevalence helps, but how does this tiny virus actually work its way through the body and cause disease? Let's talk about the pathogenesis.
Okay, pathogenesis. The pathogenesis of B19V is a truly, I think, elegant example of viral specificity. The virus primarily replicates in erythroid progenitors.
Erythroid progenitors.
Yeah.
The cells that make red blood cells.
Exactly. These are the immature cells in your bone marrow that are on their way to becoming mature red blood cells. This very specific targeting is central to how B19V causes its most prominent clinical effects.
So it directly attacks the red blood cell factory. What makes these specific cells its primary targets of a unique lock and key?
Precisely. That's a great analogy. This specificity is largely due to the limited tissue distribution of its primary receptor, which is the blood group P antigen, also known as globocide.
The P antigen.
Think of it exactly as a lock and key mechanism. The virus has the key, and only cells displaying the P antigen lock on their surface can be efficiently entered and infected.
So if you don't have the P antigen,
then you're resistant. This is a profound biological insight. A single, naturally occurring genetic variation can confer complete immunity to a widespread virus. Indeed, rare individuals who naturally lack the P antigen are, in fact, resistant to B19V infections.
naturally immune. Fascinating.
They simply don't possess the required lock for the virus's key.
That's a fascinating example of natural genetic resistance. So once it gets inside these erythroid progenitors, what sequence of events unfolds?
Infection leads to the development of incredibly high-titer viremia.
Viremia meaning virus in the blood.
Yes, and high-titer means an astronomical number of virus particles circulating in the blood. At its peak, you're looking at over 1 trillion virus particles, or international units per milliliter.
1 trillion per ml. That's almost unimaginable.
It is a massive viral load. The immediate consequence of the virus replicating within these delicate erythroid progenitor cells is virus-induced cytotoxicity.
Cytotoxicity, cell killing.
Exactly. In essence, the virus directly kills these vital cells, temporarily halting red blood cell production.
And how does the body's immune system react to this massive viral assault on its red blood cell production lines?
In individuals with a normal, robust immune function, the immune system mounts a rapid and effective counter-response. Crucially, the IgM and IgG antibody responses are key players here.
IgM first, then IgG for long term.
Correct. These antibodies are designed to neutralize the virus, and they are typically able to resolve that transient viremia, bringing the viral load down and halt the arrest of erythropoiesis, allowing red blood cell production to resume.
This brings us to figure 197-1 from our source material, which so effectively illustrates how the host's immune status fundamentally alters the outcome of B19V infection.
Yes, that figure is excellent.
Could you walk us through what that figure reveals about these varied clinical outcomes? Let's start with 1A, the normal immune response.
Okay, figure 197-1 is truly a masterclass in host pathogen interaction, showing the spectrum of B19V disease. Let's start with figure 197-1A, which illustrates the time course in immunocompetent individuals. This leads to erythema infectiosum, or fifth disease.
Fifth disease, okay.
You see a sharp spike in B19V levels in the blood, reaching that astronomical 10^12 IUML peak around days 6-10 after infection. But almost simultaneously, the host's immune system responds.
Oh, cavalry rise.
Exactly.
Yeah.
IgM antibodies rise, followed quickly by IgG. These antibodies effectively neutralize the virus, causing viral levels to plummet rapidly.
So the virus load drops fast.
Very fast. As a result, the transient dip in hemoglobin and reticulocyte levels, our indicators of red blood cell production, is minimal and quickly recovers.
So not much impact on red cells overall.
In healthy people, no. The clinical manifestations, like the characteristic rash and arthralgia, typically appear as the immune response is at its peak, often after the viremia has already begun to resolve.
So the symptoms come later, when the immune system is fighting.
Precisely. This signifies an immune-mediated phase, rather than direct viral damage causing those symptoms at that point.
So in healthy individuals, the body clears the virus sufficiently, and the impact on red blood cells is largely transient and clinically insignificant.
Precisely. Now let's consider figure 197-1B, which depicts transient aplastic crisis, or TAC.
TAC. This is where underlying conditions come in.
Yes. This scenario occurs in individuals who have underlying conditions that cause increased erythropoiesis, meaning their body is already working overtime to produce red blood cells. Think of patients with sickle cell anemia or other hemolytic disorders,
Where red cells are destroyed faster.
Exactly. Their bone marrow is in overdrive to compensate. For these patients, even a transient cessation of red cell production, which is exactly what B19V induces, can catastrophically drop their hemoglobin levels.
Because they have no reserves.
Precisely. Their bodies lack the reserve to handle even a short interruption, leading to severe acute anemia that can be life-threatening. While the immune response eventually kicks in to resolve the acute viral replication, the clinical impact is profoundly more severe.
That makes perfect sense. Their system is already stretched to its limit, so any disruption is amplified.
Exactly. And then we have figure 197-1C, illustrating chronic anemia or pure red cell aplasia, PRCA.
PRCA. This looks like the worst case.
This represents the most severe and prolonged outcome. Here, in situations where an individual, or in the context of maternal infection, a fetus fails to mount an adequate neutralizing antibody response.
So the immune system fails.
Correct. The relytic infection of the erythroid progenitors continues unchecked. You see persistently high levels of B19V DNA in the blood, often for months or even years.
Virus levels stay high.
Yes. And crucially, the IgM and IgG antibody responses are either absent or very weak, indicating a compromised immune system's inability to clear the virus. As a result, erythroid production remains chronically suppressed, leading to persistent, severe anemia.
Chronic anemia because the factory stays shut down.
That's a good way to put it. This chronic state highlights a critical failure of the adaptive immune response to control the infection.
That figure is a brilliant way to conceptualize the host-virus interaction. It truly underscores that the outcome isn't solely dependent on the virus, but crucially on the host's immune capacity.
It's an essential concept, and it also helps us understand the timing of clinical symptoms. For example, the immune-mediated phase of illness typically begins 2-3 weeks after the initial infection.
Weeks later.
Yes, correlating quite precisely with the peak of the IgM antibody response. This is when you see the characteristic rash of fifth disease appear, often accompanied by arthralgia, joint pain, and sometimes frank arthritis.
So, the classic rash isn't necessarily when the virus is most abundant, but rather when the body's immune system is actively engaging it. That's an interesting distinction.
Precisely. It's often a consequence of the immune response itself, rather than direct viral destruction causing the rash. Now, it's also important to note that even after acute infection resolves, low-level B19V DNA can be detected by PCR.
PCR, the DNA test again.
Yes, in blood and various tissues for months or even years. This persistence is usually not associated with ongoing disease in healthy individuals, but it's a detail that becomes critically important when we discuss diagnosis.
Right, just finding DNA doesn't mean active disease necessarily.
Exactly. Simply detecting DNA doesn't always imply active disease.
And since the P antigen receptor isn't exclusively on erythroprogenitors, does that explain some of the more unusual symptoms we sometimes see with B19V?
Absolutely. The B19V receptor, the P antigen, is indeed found in a variety of other cells and tissues beyond erythroprogenitors.
Like where else?
These include megakaryocytes, which produce platelets,
Ah, platelets too.
endothelial cells lining blood vessels, the placenta, the myocardium or heart muscle, and the liver. Infection of these other tissues by B19V is believed to account for some of the more unusual and less common clinical presentations, extending the effects beyond just red blood cell issues.
Let's delve deeper into those diverse clinical manifestations. It sounds like B19V can wear many hats.
It certainly does, which makes it a fascinating, if sometimes challenging, virus to diagnose clinically. While many B19V infections are actually asymptomatic or cause only a mild, nonspecific illness,
Many people don't even know they have it.
quite possibly, but the main symptomatic manifestation in children is what we call erythema infectiosum, widely known as fifth disease or, quite vividly, slapped cheek disease.
Slapped cheek is such a distinctive descriptor. How does that typically present in children?
The infection usually begins with a minor febrile prodrome.
Mild flu-like symptoms first.
Yes, a period of mild flu-like symptoms, such as a low-grade fever, chills, headache, and muscle aches, appearing about 7 to 10 days after exposure. Then, typically several days later, the classic facial rash develops,
The slap arrives.
giving the child that distinctive bright red slapped cheek appearance. After about 2 to 3 days, this characteristic erythematous macular rash may spread to the extremities in a lacy reticular pattern, often sparing the palms and soles.
Lacy pattern on the arms and legs. Okay,
Mhm.
so it starts on the face and then progresses downwards and outwards.
Mm.
Is the rash always that classic?
While the slapped cheek is hallmark, its intensity and distribution can vary quite a bit, making it occasionally difficult to distinguish from other viral rashes.
Can look like other things.
It can. A crucial point to remember for professionals is that adults typically do not exhibit the slapped cheek phenomenon.
No slap cheek in adults.
Generally not. Instead, adults, and particularly women, often present primarily with arthralgia, significant joint pain, with or without the more generalized macular rash. This is a key diagnostic differentiator.
That distinction between children and adults, especially with the joint pain, is really important. Could you tell us more about this polyarthropathy syndrome and who it typically affects?
This syndrome is a significant manifestation of B19V infection, especially in adults. While uncommon in children, arthropathy occurs in a substantial number of adults, around 50% of symptomatic cases.
Half of adults with symptoms get joint issues.
Roughly. And notably, it's more common in women than in men. The joint involvement is often symmetrical, affecting the small joints of the hands and feet, as well as the knees and ankles, leading to pain, stiffness, and sometimes swelling.
Symmetrical like both hands or both knees. How long does this joint pain usually persist, and can it be debilitating?
The symptoms usually resolve spontaneously within a few weeks, which is good news. However, in some individuals, particularly adults, recurring symptoms can unfortunately persist for months, impacting their quality of life.
Can linger for months.
It can. What's particularly interesting and a point for careful clinical consideration is that the illness can sometimes closely mimic rheumatoid arthritis.
Mimics RA.
Yes. Furthermore, rheumatoid factor, an antibody typically associated with rheumatoid arthritis, can sometimes be transiently detected in the serum of B19V patients.
RF can be positive. That could be confusing.
Very confusing. There's also evidence suggesting that B19V infection may trigger or exacerbate underlying rheumatoid disease in susceptible individuals, and it has been associated with juvenile idiopathic arthritis.
So not just a mimic, but potentially a trigger for other autoimmune conditions.
Wow. You previously discussed transient aplastic crisis, or TAC, in the context of pathogenesis. Let's explore what that actually looks like clinically and why it's so severe.
Right. While most healthy individuals with B19V infection experience an asymptomatic, transient dip in reticulocytes' young red blood cells TAC, is a dramatically more serious acute manifestation.
It's much more severe.
It almost exclusively occurs in patients who are already dependent on continuous rapid production of red blood cells to maintain adequate oxygen levels.
The ones with underlying hemolytic conditions we talked about? Exactly. We are talking about individuals with pre-existing hemolytic disorders such as sickle cell anemia, thalassemia, hereditary spherocytosis, or those with red cell enzymopathies like G6PD deficiency or even autoimmune hemolytic anemias. Their bodies are already working overtime in a precarious balance.
So for these patients, B19V essentially slams the brakes on their already maxed out red blood cell production.
Exactly. These patients present with sudden, severe symptoms of anemia, which can be profoundly life-threatening.
What kind of symptoms?
They'll exhibit extreme fatigue, pallor, shortness of breath, and often a very low reticulocyte count, a stark indicator that their bone marrow has stopped producing new red blood cells.
Reticulocytes crash.
Yes. If a bone marrow examination is performed, it typically shows a characteristic picture, a dramatic absence of erythroid precursors.
The precursor cells are gone.
Gone, along with the presence of distinctive, abnormally large, immature red blood cells known as giant pronormoblasts. Despite its severity, the illness is, as its name suggests, transient.
Transient, so it gets better.
It generally resolves as the patient's immune system finally clears the cytopathic infection.
But if the immune system doesn't get it under control, that leads to a more chronic and persistent state, doesn't it?
It absolutely does, leading to pure red cell aplasia, or PRCA, which manifests as chronic anemia.
PRCA, chronic anemia.
This chronic B19V infection is primarily observed in a range of immunosuppressed patients. This includes individuals with congenital immunodeficiency, those with advanced HIV/AIDS, patients undergoing chemotherapy for lymphoproliferative disorders, especially acute lymphocytic leukemia, and organ or bone marrow transplant recipients.
The people with weakened immune systems.
Correct. Their compromised immune system simply cannot mount an effective antibody response to clear the virus.
And what are the key diagnostic indicators for these patients compared to those with TAC? How do we tell it's chronic?
These patients typically exhibit persistent anemia and often reticulocytopenia. A key distinguishing feature is that they usually have absent or very low levels of B19V IgG antibodies,
Low or no IgG.
which is a telltale sign that their immune system is failing to clear the virus effectively. Critically, they also present with high, persistent titers of B19V DNA in their serum, indicating ongoing, uncontrolled viral replication.
High DNA levels that stay high.
Exactly. Bone marrow examination often reveals scattered giant pronormoblasts. Rarely, the impact of chronic B19V can extend beyond just red blood cell lines, affecting other hematologic lineages.
Affecting white cells or platelets, too.
It can lead to transient neutropenia, lymphopenia, and thrombocytopenia, including cases of idiopathic thrombocytopenic purpura. Occasionally, it can even trigger hemophagocytic syndrome.
Hemophagocytic syndrome, that sounds serious.
It's a rare but severe inflammatory disorder where certain immune cells inappropriately destroy blood cells.
You mentioned some intriguing studies connecting B19V to malaria. What do those insights tell us about co-infection?
Yes, this is a fascinating and crucial area of research, particularly in regions where both infections are endemic. Studies from Papua New Guinea, Gabon, and Ghana.
Where malaria is common.
Exactly. Where malaria is highly prevalent suggests that co-infection with Plasmodium, the parasite responsible for malaria, and B19V plays a major synergistic role in the development of severe anemia in young children.
Synergistic, so worse together than either alone.
That's what the evidence suggests. While case reports of this co-infection leading to severe anemia are rare in other parts of the world, these findings highlight a critical area for further study.
To see if it happens elsewhere.
Yes, to determine if B19V significantly contributes to the burden of severe anemia in other malarial regions globally. It underscores the complex interplay between multiple pathogens and host factors in disease severity.
Another deeply concerning manifestation is when B19V infects pregnant women, potentially leading to hydrops vitalis. Can you elaborate on this specific risk?
This is indeed one of the most serious complications of B19V infection. Infection during pregnancy carries a specific risk, potentially leading to hydrops vitalis.
Which is fluid buildup in the fetus.
Yes, an abnormal and life-threatening accumulation of fluid in at least 2 fetal compartments and/or fetal loss. The risk of transplacental fetal infection, meaning the virus passing from mother to fetus, is estimated to be around 30%.
30% transmission risk.
And of those fetuses who do become infected, the risk of fetal loss is about 9%, with the majority of these losses occurring predominantly in the early second trimester of pregnancy.
Higher risk in the second trimester.
Prominently, yes.
And what about the long-term impact on the baby if they survive an in utero infection? Is B19V considered teratogenic, causing birth defects?
The good news is that the risk of congenital infection, meaning the baby is born with the infection, is quite low, less than 1%.
Less than 1%.
And critically, B19V does not appear to be directly teratogenic in the classic sense, meaning it doesn't typically cause major structural birth defects by interfering with fetal organ development in the way some other viruses might.
Not like Zika or rubella, then.
Not in the same way, no. However, there have been anecdotal cases reported of eye damage and central nervous system abnormalities, as well as congenital anemia, suggesting some potential for long-term impact.
Anecdotal cases, so not definitively proven.
Correct. It's also important to recognize the significant contribution of B19V to a specific clinical picture. It's estimated to cause 10–20% of all cases of non-immune hydrops.
10–20% of non-immune hydrops, so it's a major cause of that condition.
It is a major recognized factor in this severe fetal condition, yes.
Finally, what about those unusual manifestations that don't fit the typical patterns? It seems B19V can surprise us.
These are rare but well documented. B19V infection may occasionally cause a range of other conditions beyond its primary hematologic and dermatologic effects.
Like what?
These include hepatitis, inflammation of blood vessels, vasculitis, inflammation of the heart muscle, myocarditis, kidney damage, glomerulosclerosis, or even meningitis.
Wow, liver, vessels, heart, kidneys, brain lining.
A variety of other cardiac manifestations, central nervous system diseases, and autoimmune conditions have also been reported in association with B19V. However, this is precisely where that earlier point about persistent viral DNA becomes critically important for clinicians.
The lingering DNA issue again.
Yes, B19V DNA can be detected by PCR for years in many different tissues, even in perfectly healthy individuals who have no active disease. This finding, while interesting scientifically, is of no known clinical significance in healthy carriers.
So finding it doesn't mean it's causing the unusual symptom.
Exactly. Its interpretation can cause significant diagnostic confusion regarding whether B19V is truly the cause of a specific, unusual disease if not interpreted carefully in the clinical context, considering viral load and antibody response.
Context is key.
Absolutely. Simply finding the DNA does not automatically confirm it's the culprit.
That persistence of viral DNA definitely adds a layer of complexity to diagnosis. So speaking of diagnosis, how do we actually go about identifying these infections? Let's take a deep dive into the lab tests professionals use.
Okay, lab diagnosis. For immunocompetent individuals, those with a healthy immune system, the diagnosis of B19V infection is generally straightforward and relies primarily on the detection of B19V IgM antibodies.
IgM, the acute antibody.
Correct. IgM is what we call an acute antibody, meaning it's one of the first types of antibodies produced by your immune system during a new infection.
When can we expect these IgM antibodies to become detectable?
IgM can typically be detected at the time of the characteristic rash and erythema infectiosum, or as early as the third day of transient aplastic crisis in patients with underlying hematologic disorders.
So pretty early in the symptomatic phase.
Yes. These IgM antibodies usually remain detectable for a window of about 3 months, providing a reliable marker for recent infection.
3-month window for IgM.
Roughly. In contrast, B19V IgG, which represents your long-term immunity, becomes detectable by about the 7th day of illness and, importantly, persists throughout life.
IgG means past infection or later stage acute.
Correct. Its presence indicates a past infection and generally lifelong immunity.
Okay, so IgM for recent, IgG for past. But what about those more severe cases, like early TAC or chronic anemia, where the immune response might be impaired or delayed? How do you diagnose those?
This is where understanding the quantitative aspect of viral load becomes absolutely critical for mastering this topic. For the diagnosis of early TAC or chronic anemia, simple antibody tests, while helpful, aren't enough on their own.
You need more than just antibodies.
Definitely. Here, quantitative detection of B19V DNA in serum is absolutely necessary. The emphasis is truly on quantitative PCR, not just a qualitative positive or negative result.
Quantitative PCR, measuring the amount of virus. Why is that quantitative aspect so crucial? You mentioned B19V DNA can linger for a long time.
Exactly, because B19V DNA can be detected by PCR for months or even years after infection, even in healthy individuals. A simple positive PCR result doesn't tell you if it's an active, clinically significant infection causing the current illness.
Just tells you it's there or was there.
Right. Quantitative PCR, however, measures the amount of viral DNA present. At the height of viremia and acute infection, you'll see extraordinarily high levels, often exceeding 1,012 B19V DNA international units per milliliter of serum.
Those trillion levels again.
Yes. These titers then fall rapidly, typically within 2 days, as the immune system successfully clears the virus. So a sky-high titer is a strong indicator of acute active infection.
So if you're looking at a patient with suspected aplastic crisis or B19V-induced chronic anemia, what kind of titers would you expect to see, and how do they inform diagnosis?
In those specific patient populations, those with acute aplastic crisis or B19V-induced chronic anemia, the initial titers are often indeed very high, typically above 1012 IU/mL, reflecting the intense viral replication.
So sky high initially.
Yes. But, crucially, in the absence of effective treatment for patients with persistent chronic infection, their titers should remain significantly elevated, usually above 106 IU/mL.
Above 1,000,000 copies per ml persistently.
Correct. This persistent high viral load, when combined with their clinical symptoms and often a blunted or absent antibody response, definitively confirms an active, uncontrolled chronic infection that requires intervention. It's the sustained high level that distinguishes it from residual DNA.
The source also provides a very practical table summarizing the diagnostic markers for each major manifestation. Let's walk through that, as it really helps solidify this complex diagnostic puzzle for us.
Yes, Table 197-1. It's an excellent summary table that clarifies the specific diagnostic approach for each clinical scenario. For fifth disease in healthy children,
The standard case.
you would typically expect a positive IgM, indicating recent infection, along with a positive IgG, showing developing immunity. PCR would likely be positive, and quantitative PCR would usually show titers above 104 IU/mL,
Above 10,000. Okay.
reflecting active, though generally transient, viral replication.
And for polyarthropathy syndrome in healthy adults, particularly women, does the diagnostic picture change much?
Not significantly. Similar to fifth disease, you look for positive IgM, ideally within 3 months of symptom onset, a positive IgG, and a positive PCR. Quantitative PCR would also typically be above 104 IU/mL, confirming the active B19V infection.
So similar profile, just different symptoms often.
Exactly. The presence of IgM is key for dating the recent infection in these cases.
Now, for transient aplastic crisis in patients with increased erythropoiesis, the diagnostic picture fundamentally shifts, correct?
It shifts dramatically because of their impaired capacity to tolerate even transient erythroid suppression. Here, IgM can be either negative or positive, and IgG can also be negative or positive,
Antibodies can be variable.
depending on how early in the crisis you test and how quickly the patient's immune system mounts a response. The definitive diagnostic tool here is PCR, which will be positive, and crucially, quantitative PCR.
Quantitative PCR is key here.
Absolutely. At the time of acute anemia, you would expect very high titers, often above 1012 IU/mL. These titers can decrease rapidly as the acute crisis resolves or as the body begins to clear the virus, but the initial high peak is characteristic.
That massive initial viral load is the signal.
The absolute viral load at the moment of severe anemia is key.
And what about persistent anemia pure red cell aplasia in immunocompromised patients? This is where the immune response is notably lacking.
Precisely. In these cases, IgM is typically negative or only weakly positive, and IgG is also negative or weakly positive.
Antibodies are low or absent.
Yes, this indicates a poor or entirely absent antibody response, which is why the infection persists. PCR will be positive, and quantitative PCR is essential. While initial titers might be very high, reflecting uncontrolled replication, in the absence of treatment, you would still expect titers to remain high, usually above 106 IU/mL.
Still above that million mark, ongoing.
Reflecting that ongoing, chronic, and uncontrolled viral replication, this persistent high load differentiates it from past infection.
Finally, for hydrox fetalis or congenital anemia in fetuses, how do we diagnose that given the unique context?
Diagnosis in the fetal setting typically relies on the direct detection of B19V DNA via PCR, usually performed on amniotic fluid or fetal tissue obtained through procedures like amniocentesis or chordocentesis.
Testing the amniotic fluid or fetal blood.
Correct. This PCR result would be positive for B19V DNA. Fetal IgM and IgG can be negative or positive depending on the stage of infection and the fetal immune development. Quantitative PCR is less commonly applied to direct fetal samples in this context.
So just detecting the DNA is usually enough there.
The primary focus is usually on confirming the presence of the virus in the affected tissues or fluids to establish the cause of the hydrops.
That table truly crystallizes the diagnostic approach, offering clear pathways for each scenario.
Right.
So once a B19V infection is diagnosed, what do we do about it? What are the available treatment options?
This brings us to a significant challenge in the field. Currently, there is no specific antiviral drug that has been approved and proven effective directly against B19V.
No direct antiviral. That's a problem.
It is. Therefore, treatment often targets the symptoms and supports the patient's recovery rather than directly attacking the virus.
So for a severe manifestation like TAC, which can be life-threatening, how is that managed?
For transient aplastic crisis precipitated by B19V infection, the symptom-based treatment frequently necessitates blood transfusions.
Transfusions to manage the anemia.
Yes. This is a life-saving supportive measure to address the severe anemia and improve oxygen delivery to the patient's tissues, while their bone marrow hopefully recovers its red blood cell production.
What about those immunosuppressed patients with chronic infection who can't clear the virus on their own? This seems like a different challenge entirely.
For immunosuppressed patients with persistent B19V infection, there are a couple of key strategies. If the patient is receiving chemotherapy,
Like cancer patients.
exactly, a temporary cessation or interruption of their chemotherapy treatment may, in some cases, allow their suppressed immune system to recover sufficiently to finally mount an effective immune response and clear the virus.
Give the immune system a chance.
Right. However, if this approach isn't successful or isn't clinically feasible, the primary treatment is the administration of commercial immune globulin, commonly known as IVIG.
IVIG, antibody therapy.
Yes. This product is derived from pooled plasma of healthy blood donors.
And how exactly does IV work in these persistent infections?
IVIG contains a broad spectrum of antibodies collected from thousands of donors, and crucially, this pool of antibodies includes neutralizing antibodies against B19V.
So it provides the antibodies the patient can't make.
Precisely. Administering IVIG can be remarkably effective, often leading to a complete cure or significant amelioration of persistent B19V infection in immunosuppressed patients. The typical dosage is around 400 milligrams per kilogram of body weight, given daily for 5 to 10 days.
Gives them the tools to fight it off.
Essentially, yes. It's providing the patient with the specific, potent antibodies their own compromised immune system cannot produce to finally bring the viral load under control. It's also important clinical guidance that patients with TAC and immunosuppressed patients with persistent B19V infection should be considered infectious.
Still infectious, even with treatment.
They should be considered potentially infectious until definitive evidence of viral clearance is confirmed.
Okay, good precaution. So IVIR is a game changer for these chronic, life-threatening cases. But is it also used for the more common, self-limiting manifestations like fifth disease?
No, absolutely not. The administration of IVIG is explicitly not beneficial for erythema infectiosum or for B19V-associated polyarthropathy.
Not for fifth disease or the joint pain.
Correct. Those conditions are typically self-limiting, and the immune system usually mounts an effective response to clear the virus and resolve symptoms without the need for external antibody therapy. IVIG is reserved for the severe, chronic, or life-threatening presentations where the host's immune response is inadequate.
And for the devastating complication of fetal hydrops, what interventional strategies are available?
In some severe cases of fetal hydrops caused by B19V infection, intrauterine blood transfusion can be a life-saving measure.
Transfusing the fetus directly.
Yes. By directly transfusing red blood cells into the anemic fetus, it can prevent fetal loss and improve outcomes by alleviating the severe anemia. This is a highly specialized and delicate procedure, but it offers a crucial intervention.
Okay, so treatment is largely supportive or antibody-based for severe cases. What about prevention? Are we able to prevent B19V infection in the first place?
Currently, there is no vaccine that has been approved for the prevention of B19V infection.
No vaccine yet.
Not approved, no. However, significant research efforts have been and continue to be underway. Scientists have explored vaccine candidates based on B19V virus-like particles, or VLPs.
Virus-like particles, empty shells.
Essentially, yes, non-infectious shells that precisely mimic the outer structure of the virus. These virus-like particles are typically expressed in insect cells and are known to be highly immunogenic.
They trigger a strong immune response.
Yes, generating protective antibodies.
That sounds incredibly promising for a vaccine. Why isn't there one available yet then?
Unfortunately, despite the promising immunogenicity, Phase 1 clinical trials of a putative vaccine were discontinued specifically because of unacceptable adverse side effects.
Side effects stopped it.
Yes. So while the scientific pathway to a vaccine looks plausible, there are still significant hurdles to overcome in terms of safety and efficacy before a viable and approved vaccine can be made available to the public. It's a reminder that vaccine development is a long and challenging road.
That's a truly comprehensive look at parvovirus B19. But as you mentioned earlier, it's just one branch of a larger family tree. Let's broaden our scope and explore the other human parvoviruses, starting with the human tetraparvoviruses, specifically PARV4 and PARV5.
Certainly, PRV4 was initially identified relatively recently in a patient presenting with an acute viral syndrome. Subsequently, similar genetic sequences, including the closely related PRV5, were detected in pooled plasma collections,
Found in blood donations again.
indicating their presence in the human population. What truly sets these viruses apart from other parvoviruses we have discussed is their distinct DNA sequence, which led to their classification into a newly described genus, tetraparvovirus.
A whole new genus.
Yes, highlighting the ongoing discovery process in virology.
So a genuinely new branch of the parvovirus family. How prevalent are they, and how do they appear to spread?
Well, PRV4 DNA is indeed commonly found in plasma pools, though generally at lower concentrations than the B19V DNA historically found before widespread NAT screening.
Lower levels than B19V.
Generally. When it comes to transmission, the evidence for PRV45 points towards a predominant parenteral route, meaning transmission outside the digestive tract, often through blood or bodily fluids, especially in the United States and Europe.
Parenteral, like blood exposure.
Yes, this is strongly suggested by higher levels of PRV4 DNA and IgG antibodies found in tissues like bone marrow and lymphoid tissue, and particularly in the sitara of intravenous drug users compared to control populations.
So similar to B19V's transfusion risk, but perhaps more associated with other forms of blood-borne exposure.
Exactly. However, it's important to note that evidence for non-parenteral transmission in other parts of the world is quite limited, so the epidemiology might vary geographically.
Might spread differently elsewhere.
It's possible, suggesting different modes of spread depending on the region and population behaviors.
And what do these PRV45 infections actually do to people clinically? What kind of symptoms are associated with them?
To date, the clinical picture associated with PRV45 infection has generally been mild.
Generally mild. Okay.
We're talking about presentations such as a rash and/or a transient elevation of aminotransferases, which are key liver enzymes, suggesting a mild and temporary liver involvement.
Rash, maybe some liver inflammation.
Exactly. They have not been widely associated with severe or life-threatening illnesses, unlike some of their parvovirus cousins.
Okay, let's move on to the human bocaparvoviruses, or HBoVs. What's their story, and how do they relate to what we know about animal bocaparvoviruses?
Right, HBoVs. The animal bocaparvoviruses offer some context, as they're known to be associated with mild respiratory symptoms and gastroenteritis in animals.
And gut issues in animals.
Yes. HBoV1, the first human bocaparvovirus, was initially identified in 2005 in the respiratory tract of young children who presented with lower respiratory tract infections.
Found in kids with respiratory infections.
Correct. More recently, HBV1 and its closely related viruses HBoV2, HBV3, and HBoV4 have all been identified in human fecal samples.
In stool samples, too.
Yes, suggesting a potential role not just in respiratory illness, but possibly in gastrointestinal illness as well.
How widespread are HBoVs in the human population?
Seroepidemiologic studies, which analyze the presence of antibodies using HBoV virus-like particles, suggest that HBoV infection is remarkably common globally.
Very common worldwide.
Yes. Most individuals are infected before the age of 5 years, indicating widespread early childhood exposure, similar to many other common childhood viruses.
Get it early in life. And clinically, what symptoms do they typically cause in children, especially in the respiratory context?
HBoV1 DNA is found in respiratory secretions from a significant percentage of children ranging between 2% and 20% who present with acute respiratory infection.
Found often in sick kids' airways.
Yes. However, and this is a critical point for clinical interpretation, HBoV1 is very often found in the presence of other respiratory pathogens simultaneously.
Co-infections are common.
Very common. In such co-infection scenarios, the specific independent role of HBoV1 in causing disease can be quite unclear. It raises the question, is it truly the primary culprit or an innocent bystander or cofactor?
So it's hard to pin the disease solely on HBoV1 if other pathogens are present. How do clinicians try to attribute disease specifically to HBoV1?
That's why specific criteria are important for attributing clinical disease directly to HBoV1. These criteria include evidence of primary infection, such as IgG seroconversion, meaning a new rise in IgG antibodies, or the presence of IgM antibodies.
Showing a new or recent infection?
Right. Alternatively, The detection of HBoV1 DNA in serum, which suggests systemic infection, or a high titer of HBoV1 DNA above 104 genome copies per milliliter in respiratory secretions are considered indicative of active, clinically relevant infection.
High levels in the airways or finding it in the blood.
Exactly. The symptoms when HBoV1 is implicated are not dissimilar from other viral respiratory infections, with cough and wheezing commonly reported.
And is there any specific treatment available for HBoV infections?
No. Similar to many other viral respiratory infections, there is no specific antiviral treatment currently available for HBoV infection. Management is largely supportive.
Supportive care.
Yes. Furthermore, despite their frequent detection in fecal samples, the definitive role of HBoVs in childhood gastroenteritis remains to be firmly established and requires further research.
Still uncertain about the gut connection.
That's right.
Finally, we come to the human protoparvoviruses. Bocaparvovirus, tussivirus, and cutevirus. These names sound like they emerged from the cutting edge of viral discovery.
They absolutely did. Bocavirus, tussivirus, and cutevirus were all identified in clinical samples using a groundbreaking approach called metagenomics.
Metagenomics. Looking at all the genetic material.
Precisely. This is a powerful tool for discovering new and previously unknown pathogens by analyzing all genetic material present in a sample, rather than relying on methods that target specific, already known organisms.
So finding the unknown unknowns.
Kind of, yes. These viruses are now classified as members of the protoparvovirus group, alongside the original prototype member of the entire Parvoviridae family, the minute virus of mice. It really speaks to how much we're still learning about the viral landscape.
That's a testament to how advanced detection methods are continuously expanding our understanding of the viral world. But what do we know about their epidemiology? It sounds like information might be limited.
You're right, relatively little is known about the epidemiology of these newly discovered viruses. However, what limited seroprevalence data we have shows some truly fascinating geographic patterns in antibody prevalence.
Different patterns in different places.
Yes, suggesting localized endemicity. For example, antibodies to bocavirus were found to be very low in populations in countries like Finland, the United States, less than 4%.
Very low in U.S. Finland.
But in stark contrast, they were detected in over 50% of populations surveyed in countries like Iraq, Iran, and Kenya.
Over 50% there. That's a huge difference.
It hints at significant regional differences in exposure and circulation.
That's a huge disparity. What about cutevirus and tussivirus?
Antibodies against cutevirus were found in less than 6% of all populations surveyed, suggesting it's considerably less common globally than bocavirus.
Cutevirus seems rarer.
Yes. And remarkably, tussivirus antibodies were found in none of the populations tested, highlighting its extreme rarity. Tussivirus has, in fact, only been identified in a single patient with diarrhea in Tunisia.
Only one patient ever for tussivirus.
Wow. This singular detection makes its definitive status as a human pathogen still quite unclear, posing a significant challenge for researchers.
So their clinical manifestations are probably still very much a mystery then?
Indeed. While bocavirus DNA has been found in 0.2% to 4% of stools from children and adults with diarrhea in many countries, it's very often co-detected with other known gastrointestinal viruses.
Bocavirus found in diarrhea, but often with other bugs.
Exactly. This makes it difficult to ascertain its precise role in causing childhood gastroenteritis, and its pathogenicity still needs to be confirmed. As for cutevirus,
What about cutevirus?
it has been detected in biopsies of individuals with cutaneous T-cell lymphoma and melanoma, raising questions about potential associations. But importantly, it has also been found in skin swabs from healthy individuals.
Found in skin cancers, but also on healthy skin.
Yes, which presents a significant diagnostic puzzle. Is it a true pathogen in some cases, or merely a commensal organism on the skin, or even an environmental contaminant? There's a lot more to uncover about these recently discovered viruses.
This has been an incredibly enlightening deep dive, from their incredibly small size and unique replication strategies to the diverse and sometimes surprising clinical pictures they present. It's clear that these tiny parvoviruses, despite their microscopic nature, exert significant and varied impacts on human health.
It's truly a testament to the power of these microscopic entities. We've explored how B19V, most well understood, can range from causing the classic, often mild fifth disease to severe, life-threatening anemias,
All depending on the host.
all profoundly influenced by the host's immune status. And then we've touched on the more recently discovered human tetraparvoviruses, bocaparvoviruses, and protoparvoviruses, each with their own unique characteristics and, in some cases, still very mysterious or unclear roles in human disease.
So for you, the listener, armed with this level of detailed understanding, what does this all mean? Why is mastering these nuances so crucial?
Understanding the specific biology of each parvovirus, their unique modes of transmission, their targeted cells, and their diverse clinical manifestations is absolutely crucial for accurate diagnosis, effective management, and informed public health strategies.
Knowing the details matters for patient care.
Absolutely. Knowing when to suspect a B19V infection based on symptoms, how to properly diagnose it using quantitative PCR, and recognizing the fundamental difference in management for an immunocompetent child versus a severely immunosuppressed adult or a vulnerable fetus can literally change patient outcomes.
Makes a real difference.
This comprehensive understanding moves beyond just memorizing names. It equips you with the depth of insight needed to truly grasp their impact on human health.
That's the core of it, isn't it? Understanding the why behind the what. And as we wrap up this deep dive, it leaves us with a truly provocative question, especially given how advanced detection methods like metagenomics unearthed some of these newer parvoviruses.
Indeed. Consider the profound implications of continuously discovering new viruses, many of which initially present with unclear pathogenicity. How might our understanding of mild or asymptomatic infections evolve as our ability to detect these viruses becomes even more refined?
We keep finding more things. What do they all mean?
Exactly. We're finding more and more viruses in seemingly healthy people or frequently co-present with other known infections. What are the broader public health implications of these ongoing discoveries, particularly for newly identified viruses that show high seroprevalence in certain regions or for those consistently found in co-infections?
What's their real role?
What new questions arise about their true individual and collective roles in human disease? And what does this mean for the delicate, ever-changing balance of our viral landscape? It's a field that is constantly revealing new layers of complexity.